doesn't make it to this one and watch the video later, does he still need to talk to you?
No, this is good questions. Essentially, what we're doing is to do with the legislation, which I'll get into. But essentially, in order to be understanding orders, you need to be trained. So I need to actually do some education, and that can be by watching a video that I've made. You need to be certified by doing a very hard quiz. And a couple of you have already done that quiz. And then audited. So that's basically what the legislation states. So cool. So I will just load up PowerPoint and that one. And then we'll kick in. So alrighty, so beverages at the ready. Let's get into it. So my name's Paul. I am a doctor based in Hamilton. I do some outdoor stuff with an interest in providing care in the outdoors. So I've met Dan a couple of times through various Landsat courses, and we talked, and Dan thought it'd be a good idea to be able for you guys to give some drugs as part of what you do for Rescue 3. This talk is basically designed for search and rescue teams, and so I'm going to use the same talk, and it's pretty much the same concepts, just where it says search and rescue, it's going to be for you guys. So we're going to talk about what having a doctor on your team basically is, and what things I can provide for you. What are standing orders? What are some of the common questions that I've been asked about them? Go through all the individual drugs super quickly. We're not going to dwell on anything and get into pharmacology. What documentation standards we need in the audit process. I'm going to take it at a level that you're all kind of fact-based providers. You all got some experience. You all know a thing or two about looking after people. But don't be afraid to sing out, ask questions. Okay, I love questions. I'd rather answer something even at you think might be a very basic level than have there be any confusion. And you can also reach out to me afterwards if you've got questions about anything, whatever. Just ask, sing out, because if you're thinking it, the other guys might be thinking it, and yeah. So let's see if we can make this advance. Yeah, cool. So with search and rescue teams, medical oversight is where you have a doctor who's kind of part of the team but not directly involved in it. They can be part of the team, but what they do is they're there as a resource, and that's what I'm going to be for you guys. I will be a resource. I will add some medical knowledge on top of yours. I'm not going to tell you how to do your job. That's not what I'm here for. I'm going to be there as it's a bit like an encyclopedia to look up stuff. If you say, well, I've got this situation in front of me, I'm not sure which way to go here or there, what do you think? Or we've been called to this is a scenario, what are the things we need to look for? Those are the things where you can just give me a call and say, what's the go? Or if you have an event where things maybe go, not so well or interesting, but you deal with it and want to get a bit more into the weeds about what went on and why, then totally give me a call. I'm happy to talk through those. I think that people who get involved in providing medical advice for people who do stuff in the austere or remote environment should have some knowledge about what can be achieved in search and rescue and in kind of FEC type medicing roles, and should have a knowledge of the environments that you guys are operating in when you're kind of doing events and stuff that's a little bit more out in the wilds. So what I can provide is, I think I've alluded to that, I can come down and give you some teaching on various stuff. We can hold Zoom sessions. I'm available for phone advice should you need anything. And if things go wrong and you get complaints about your actions, then you use me to help defend them, to say, no, this is a reasonable thing you should have done, that you would have done, and what your expectations are unrealistic about what should have happened here, etc. So that's where I can be quite useful. And so why can I do that? Well, I've been a doctor for 20 years now. I train in urgent care, but I've also done training in what's called wilderness and austere remote medicine. Fellowship trained in that. I've got a diploma of mountain medicine, which is a International Alpine Association registered recognized qualification, and that basically takes healthcare people, gives them technical rescue training, along with some didactic work, and we have to pass tests and exams and do things like you see me there of dragging people up very snowy things. I've climbed a few mountains, do a bit of ski touring, bit of sport rock, and I do a bit of search and rescue. So that's kind of me. So let's get into the meat of the talk. So what are standing orders? This is all the legal waffle, which if you're into reading that, then feel free to get stuck into. But in English, it basically says that you guys can prescribe medicines on my behalf while I'm not there. So you're actually giving meds on my medical council number. Because in New Zealand, there's only two people who can prescribe medications. One is a doctor and one is a dentist, okay? And so every time you see a St. John's person giving meds, they're not the one giving the meds, they're giving it on behalf of a doctor in Auckland. Every time you go to ED and the nurse gives you a couple of pills, they're doing it on a standing order that's signed. In order to work under a standing order, then you need to be trained and certified, as I alluded to earlier. And you must document to a standard and submit those and be audited on that practice. That's what all those legislation basically summarize into English. So these are the meds which I prescribe standing orders for. If there's anything that's not on here that you think would be useful or you want to talk about, then get in touch. Always happy to talk about this stuff. Always open to change and add stuff. In fact, when I started out, it was only 5 things, and the other things have been added due to the 4 things it was, and the others have been added due to people's teams requesting them. So paracetamol and ibuprofen, you know what those are. Salbutamol, which you're only going to give for known asthmatics. Ondansetron is an awesome nausea drug. Adrenaline for anaphylaxis. Loratadine is just your Zyrtec, your hay fever stuff, which is good for people who've got a bit of a rash or getting itchy eyes, hay fever symptoms. Aspirin is for people who might be having a heart attack, and Penthrox is the green whistle that you'll have seen the AMBOs give out. That's the good stuff. So what training do we need? I think I've talked a bit about that. But basically, if you guys have got FEC or equivalent or higher qualification, so like FEC, EMT, paramedic, then you can basically give all of those. And I think you are all FEC trained, so we'll just go through everything anyway. So this lecture or the video recording of it, and then you can complete the quiz, which I'm sure, I think Andrew, you've done it. You didn't find it too troubling. It's pretty basic, and it's basically because, I mean, you're all intelligent guys. You know what's going on. It's just to essentially do the minimum to tick the box. So on to the common questions I get. You know, you can go and buy Paracetamol Countdown. Why do you need all this training and shenanigans to give it when you're working for Rescue 3? Well, legally, this is quite unclear. It's never really been tested properly, and I've tried to badger my medical protection lawyers into actually trying to get into this, and they're just not interested. There's no test case. So when you think about drugs, you can class them into kind of off-the-shelf paracetamol and ibuprofen. If you're carrying that around in your pocket, no one's really going to care. If you give that to other people, well, yeah, I think that would probably be fine. No one's really going to get too upset. There is a caveat there. Over-the-counter medications such as hay fever stuff, again, no one really cares. Now, if you're carrying around prescription drugs and they're not prescribed to you, then you know that might be a little bit challenging as to why you're carrying those around. And then if you're into the morphines and the controlled drugs, then the police and the prosecutors are going to be interested as to why you've got that without being appropriately trained and etc. So when you are doing an event as medics, An extreme interpretation would say that you are there in a healthcare setting giving a medication to a patient, and you could call that prescribing. And as I said earlier, there's only two people that are allowed to prescribe in New Zealand, that's doctors and dentists. And that applies to everything. If you're giving a drug to a person, someone could say, well, that means you're prescribing it. Now, that's pretty extreme. But if you give someone paracetamol and ibuprofen and it's completely justified, but they have a bad outcome, the coroner might still be talking to you. And the benefit of having a standing order from me is I take all that responsibility from you. It becomes my problem, not your problem, because you have given the medication with a defined set of guidelines. And as long as you stuck into that guidelines, I bear all the responsibility, which is cool. That means that you guys just have nothing to worry about. And that's why I like to do this for SAR teams, because they carry some responsibility anyway, but being able to give medications to the patients and the injured people they serve without having the legal repercussions of it, I think is pretty cool. So whilst I say there's been no test case, this dude down in Christchurch did actually get arrested for carrying adrenaline around without a standing order. So it never actually went to court. It got dropped. And speaking to some guys I know down there, the guy's a kind of interesting character, shall we say, who has previous cases for interpreting and impersonating police. And so I'm pretty sure there was a little bit more to meets the eye. But I say, you guys probably don't really want to have that process either. So getting standing orders, following those, it means that you guys can give reasonable care to patients without having any concerns about the legality of it. So with that being said, if you have a person in front of you and you're not sure, uncertain, or all this you're just not interested in and you just want to do what you've done before, do you need to give medications? No. Never feel obliged to give a medication if you're unsure or unhappy, or if someone else has told you to, because essentially you do carry some responsibility to make sure it's done by the standing order. If someone comes up to you and says you should have given that, and you're like, well, no, I was unhappy, then send them to me and I will talk to them. I will set them straight. So yeah, so don't feel you have to give stuff if you think, well, I'm not sure this fits in the indications. I'd rather you guys are cautious than cavalier. What about pregnant people? Most of these medications are fine, okay? And reality is you could probably give all of them and be just fine. There are just a couple of little kind of minor risks. So ibuprofen, paracetamol, safe as houses, yeah, no worries. Ibuprofen, first and third trimester, possibly a small risk, but really it's tiny. But if the patient's pregnant, then ask them. So if they're first trimester and it's not that bad, they'll probably say, well, yeah, I'll take some paracetamol, but not ibuprofen. Salbutamol, loratadine, no worries. Aspirin, if they're having a heart attack, if they're pregnant, don't give it, but they shouldn't really be having a heart attack at that age. So just check you're happy with the diagnosis. On Danstron, there is a very, very tiny risk of your increase the risk of cleft palates. Now, the risk of a cleft palate in a otherwise normal pregnancy is very, very, very low, and it increases it to just slightly more than very, very, very low. So it's a risk-benefit situation. Now, I give ondansetron to pregnant women that are vomiting profusely pretty regularly, and I am not worried about that risk. If you have to drag someone into a stretcher, maybe in a technical rescue or through a bit where you can't really manage the airway well and you really don't want them vomiting, I think your risk-benefit ratio there is definitely to give it. But if you can avoid it and they're pregnant, then again, you probably should. So it's, again, a risk-benefit situation. Don't get too stressed and think you're going to kind of cripple their baby with a cleft lip by giving them the chance of it is vanishingly remote. Penthrox, again, possible tiny risk in the last trimester. if they're broken enough to use Penthrox, then probably give it, because them being in intractable pain may cause damage to their baby as well. So again, risk benefits, see how bad they are. If you can avoid it, not. But if they're that broken and need it, use it. And if you're worried, give me a call, and then you can write in your note, discuss with me, and I've said okay or no. Then again, you're further covered. Interactions, you can pretty much give them all together. You have to give a lot of salbutamol before the ondansetron cause problems. If you're giving that much salbutamol, you need to be kind of getting help anyway, because they're all clearly quite sick. We're going to go through this pretty quickly because these are all the basic drugs, that most of which you'll know. So paracetamol, 2 pills. Pain and fever, it's metabolized by the liver, so don't give it to patients with bad livers. Pretty much for all the patients you're going to be giving stuff to, they need to be alert and orientated enough so you can take a history and make sure they don't have any allergies. Don't give any pills to those who should be nil by mouth. So if someone's got really bad abdo pain and you think that something's gone pop inside their tummy, then don't give them pills. Ibuprofen, again, 2 pills, goes out by the kidneys, not good for people with bad kidneys. Now, there's a few asthmatics will get wheezy with ibuprofen. It's about 1 in 6, and they're a particular type of asthmatic. Usually they know. If they do get wheezy with ibuprofen, obviously don't give them more, and you've got your salbutamol as well. Salbutamol, this basically relieves the tightness of the chest, of the spasm that asthmatics get in their airways. You give it via a spacer, which basically means that with the normal inhalers, if you just put it straight to the mouth, essentially about 80% of it coats the back of your throat and doesn't actually go to your lungs. If you put it into a spacer, then it gets to most of it goes down actually into your lungs. You should only be giving this for people who are known diagnosed asthmatics who would normally have an inhaler, that either their inhaler's left at home or it's stopped working, probably because it's run out. You might find usually younger, teen, young adult women will come up to you saying they're all short of breath and they're actually just having a panic attack. If they're not diagnosed asthmatics and have an inhaler, don't give them this because it will actually make their anxiety worse. If it's people who've got overactive thyroids, low potassium, they would have to know that and tell you that. But if they're known to get funny heart rhythms, it can exacerbate those. You can give up to 6 puffs at a time, and 2 would be the normal dose, and then up to 6. And between each puff, you give 6 breaths. So puff, breathe in and out 6 times, and then they don't have to do any coordinated breathing. They can just breathe in and out as best they can, and make your assessment as to how short of breath that person. If they look really bad, yeah, give them the full 6. Give them another lot after 15 minutes. But if you're needing to give them if after 15 minutes they haven't made a remarkable recovery, then you're going to be needing to either get some help if you're away from help from civilization, or you're going to be calling St. John's and getting them on the way out of there because they're clearly doing quite badly. You can't really give too much salbutamol, so I'd rather the patient was breathing than not. So give it repeatedly every 15 minutes as you need. But if you're needing a second lot within 15 minutes, they should be exiting the field of play and heading towards definitive care. How do you use it? Picture there, shake it up, stick it in the back of the spacer, give it a puff into there, they breathe in and out 6 times. Rinse and repeat as you need. Are we going okay so far, team? Do we have any questions? We're happy with the pace.
Can I ask you a question?
Yeah, please do.
Yeah, so I'm the odd one out. I'm in Australia. So with the salbutamol, we do 4, 4, and 4. So yeah, I guess what you just said before, that's the New Zealand version. So when in country, that's the way you do it. Yeah,
I'm not sure my standing orders will work for you because the laws I've quoted are all New Zealand law.
Yeah. So that's when I'm in country, in your country. Yeah.
Yes. Yeah. So yeah, our And so for so we call it 6x6 for when like a bad asthmatic, 6 puffs with 6 breaths each.
Okay. Yep.
Yeah, that's what we do here. Yeah, okay, but essentially, I'm not sure it's going to make much difference. I guess we're just trying to maximize each puff, but yeah, whatever works as long as it's going in, we're happy.
Okay.
Yeah. So Ondansetron's fantastic medication. The great thing, the reason why I love Ondansetron is you don't have to swallow it. It comes in a little oral dispersible thing which you crunch up in your mouth, and it gets absorbed through your tongue and your lips, which is fantastic because when you feel really crook, the last thing you're going to be wanting to do is trying to swallow pills because it will just bounce. It will just come straight back at you. It lasts for about half an hour. It is metabolized by the liver. Doesn't really matter if they have liver problems because you can give them a couple of tablets within 24 hours and you're fine. The only issue you've got to ask for is something called long QT syndrome and if they're on any other meds. I'll get on to long QT syndrome in a bit. It's basically a congenital heart thing. Yeah, so heart rhythm, it's inherited. And the main symptom is sudden death. So that's a kind of a pretty radical symptom, eh? And some people don't know that they've got it, but they'll know that their dad or their uncle died suddenly at a young age, 20s, unexpectedly. So you might find these are those soccer players that run out onto the pitch and then just go collapse with seemingly no issue. A lot of people do know about it these days, though. The genetic testing, particularly in New Zealand, is pretty good. And when people come in to see me, they'll go, "Yep, I've got long QT." Giving these people Ondansetron will prolong that long QT, which is it's the time between the start of their contraction and when their heart repolarizes. It will prolong that and basically trigger them into fibrillation. Which means their heart doesn't pump, which has a bad outcome. So basically ask about, do you have long QT? Do you have a family history of people dying suddenly, unexplained? Obviously, if they're all dying of car crashes or getting shot, then that doesn't make them, it's not part of the deal. Interactions. So when I come to write standing orders, I have to make it pretty straightforward so that it's pretty straightforward for you guys. And so Ondansetron was a bit of a trouble because when it comes to interactions, Ondansetron has many. And so if they are taking things like loratadine or the oral contraceptive pill, then those two I worked out are absolutely fine. The other meds in the standing orders with the caveat of salbutamol, if they're taking any other regular medications, ask. And the reason is because I started looking at the list of interactions with salbutamol. And this is an interactions checker where they basically put in the drug and it tells you all the drugs. And there are pages and pages. And so I got to that and I thought, yeah, that's hard. So just ask. If they're on anything other than just a normal hay fever pill or the oral contraceptive pill, and you want to give Ondansetron, ask. Get hold of either St. John's or me if you can, and I can easily look it up. Are we happy with that?
Yep.
Cool. Adrenaline. Adrenaline is awesome. It's the only treatment for anaphylaxis. Anaphylaxis is essentially where you have a momentous cascade failure of your inflammatory system. We define it as involving two or more systems. So your skin is a system, so if they've got a rash, your GI system, so they get a gut ache, and that's the one that's commonly missed. Throat, tongue swelling is another one, wheeze, or if they basically hypotension is they can't stand up. They're lying flat, and if they try and sit them up, they faint. If you've got two of those, adrenaline. And adrenaline is the only treatment, and you give half a mil, and then after 5 minutes, if they're still no good, you give another half a mil. And then you keep on going until they either get better or you run out of adrenaline. So if there's a bunch of you and you've got a vial, yeah, if there's 3 of you, you'll have 6 doses. If you've all got 1 each, so that's a lot. I've never needed to give more than 3 for anaphylaxis, so you should be all right. Don't give adrenaline to someone who's not in anaphylaxis, because it will make their heart run. You can precipitate things like MIs and funny rhythms as well. However, if they are in anaphylaxis, they're going to die if you don't, so give it to them. It makes you feel horrifically bad. You feel like your world is about to end. Your heart feels like it's about to jump out your chest. You will flush. You'll feel rubbish. If any of you guys are known to have anaphylaxis, it's just basically you probably should carry your own EpiPen and have some antihistamines or prednisone as well, just because sometimes allergy can lead to anaphylaxis. How do we do it? So usually if I'm giving to the SAR teams, I use a 3 ml syringe rather than a 1 ml syringe. Way easier to draw up into a 3 ml syringe than a 1 ml syringe, and then you just give half of it. So some people use a drawing up needle, which has got a little filter so you don't get any glass fragments from the ampule. There's your adrenaline, there's your syringe. Alcohol swab, not necessary, to be honest. If you have a choice between not giving it or because you don't have a swab or giving it, just give it. We can treat infection later. The main things you need is a syringe, a needle, and the adrenaline. Suck up half of it. Grab a wodge of muscle on the middle of their thigh, kind of the front outer side of it. Hold the needle like a dart, stab it in, and then squeeze and hold for about 5 seconds. Put out, and then immediately draw up your second dose. The reason why you do this is, 1, you might need it in 5 minutes. 2, your ampule is cracked, you're not going to be carrying it out. And if you don't, and then all of a sudden, when you're moving around after you've given the first one, you might knock it over and spill it, and then you don't have it. So just do that straight away. An orange is what we were taught to practice with, and there's me saving an orange's life. Cool. Oh yeah, get rid of your sharps. Don't stab other people with them. Not fun. Loratadine. Basically, this is for people who are a little bit itchy, hay fever type symptoms. It's 1 pill, safe as houses. Don't give it for anaphylaxis. Give them adrenaline. It's not for anaphylaxis. Aspirin. For those people who usually they have known cardiac disease, sometimes not. They'll look terrible, feel like an elephant sitting on their chest or being clamped in a vice. Pain can radiate up into their throat, down their arm, sometimes into their back. They're usually sweaty and they look grey. It's not for the pain. However, it does massively help their chance of surviving this event. When they initially did the study back in the 80s, they actually had to stop the study because the results were so stark that those who got aspirin were doing so much better and the others were dying that they stopped the study before the end. They have to chew the tablet, and the thought is that then it gets absorbed through the mouth, through the tongue, and gets into the system quicker. However, it does taste awful. Can make you feel a bit sick, but then so does having an MI. If they're really messed up from trauma and you're worried about bleeding, then you might want to avoid it, and that might be the cause of why they're sick. But if you've got someone having MI and they're very broken up, they're not in a great situation. So just make the judgment call. Don't give it to pregnant people. It's really bad for them. Cool. On to the good stuff, the green whistle. This is actually a general anesthetic, and they found that in the lower dose, they can use it as good pain relief. The main use is to get a broken person into a position to be extracted. So in a search and rescue setting, you find someone in a bit of a hole, you can use it to straighten out the broken limbs and get them into a litter without them screaming too much. You've only got about 20 to 25 minutes of constant use per little vial, and you can give 2 vials back to back if you need. There is a couple of cautions. If they're particularly elderly, they can drop their blood pressure a little bit. And if they've got something called malignant hypothermia or malignant hyperpyrexia, they can die. So that's not cool. Now, malignant hypothermia, or MH, we'll call it from now, is not that common. However, Central North Island is where the kind of capital of malignant hypothermia is. Palmerston North Hospital is where all the testing and all the genetic work is done for this, because most of the families with it live near there. And that's not a long way from you guys who are in Rotorua, you know. And when I gave this talk to Raro, it really hit home, because one of the members does have this condition. And so they've actually got to be careful about when they give that, because if the person, the team member who has MH, gets too close to these guys, it can trigger MH in him. And that will be very unfun. If someone is broken and hurt enough to need the green whistle, then never send them home. They need to go to a hospital, urgent care. You need to hand them on. So MH, it's a severe reaction to general anesthetics. What happens is that the anesthetic triggers the calcium in their muscle cells to be released, which causes all the muscles to contract, and that every muscle in their body continually contracting basically causes them to overheat and cook themselves. That's how they die from this. So the first thing you'll see is the muscle, jaw muscle is thought to be the first thing you see, will start to twitch. Then they'll get a high fever, then it'll be a fast heart rate, and they'll feel pretty rough. It is inherited, mostly in the Manawatu. I say 36 groups of about 1,500 people. It was brought to New Zealand by a Dutch fur seal trapper in about the 1800s. So that's MH. If you suspect that they might be getting it, you need to stop the Penthrox, get it away from them, and call for help, because they're in a pickle. And yeah, you're not going to have a fun time if they go on to get this full blown. And what will the help tell you? The help's going to basically tell you to keep them as cool as possible. There is a drug that's given in hospitals called dantrolene. You will not have access to this in a timely fashion. You'll be cooling them, and you'll be basically stripping them down and coating them in water and ice until this effect wears off. However, it's rare. 1,500 people in 5 million people in New Zealand is not common. They all are really good at knowing that they've got it as well. All the ones that I've met, they've all been like really up on it, and they know to tell people. And the only people who don't really know about it are the kids, but the kids are usually like that 8, 9, 10-year-olds. And usually their parents do know about it, and the kids will be a question mark because they usually won't have the genetic test done. And that, if you're interested, is where you go to Palmerston North Hospital and they make a little cut in your thigh and drag out a little bit of muscle and stick it under a microscope and test it. And usually most of these families get tested around their late teens to know whether they've got it or not. So they're pretty good at telling you. So don't stress too much about the Penthrox. They usually you'll be fine. Most of you guys will have seen the green whistle.
Mm-hmm.
This is what it looks like. It's got this kind of plasticky wick inside it. I like using it with the charcoal on because I don't want to be getting high. Well, not when I'm at work. And so essentially it shows you here, you take the little cap, you pour it down the end, it goes in there, it gets absorbed by the wick, and then you breathe through it. There's lots of pretty pictures about how it works. There's a little hole on top where the charcoal goes in, and on top of that, if you want it to get more concentrate, then you push on that hole. So what you generally do is you start them off with it on loose, and you get them going, and then when you want to actually move them, if they're not getting enough effect, you'll tell them to put their finger on the hole. And the patient should be doing this. The patient should control this, and that way if they have too much and go a bit woozy, they'll just drop it and it will wear off itself. And it wears off pretty quickly. And this is just saying about covering the hole. So the key thing, self-administered, is really portable. It's really resistant to being bounced around in backpacks, and it gives really good pain relief. That's just some slide about some coaching tips. So yeah, fruity smell, it does. If you ever had the Hubba Bubba or Juicy Fruits chewing gum, it smells just like that. They will still feel stuff, but they'll be a lot happier about feeling it. And the more they use it, the quicker it will run out. So usually if you've got a very broken person, what you'll do is you'll set them up with a little bit of it, so get them going so they're used to it. And then when you're ready to move them, then you'll get them going hard on it, move them, and then get them to not take it while they're comfortable and only take it as they need if they want to shift around. Yeah, so you can give them, each pack comes with 1 bottle. Obviously, if you need a second bottle, you need to open another pack. But the most that you guys will be giving is 2 bottles, and that's fine. Any questions about Penthrox?
No.
We're all good so far?
Yep.
So how do you look after your meds? Well, that's going to be between you guys of how you kind of manage your meds. Usually for the Penthrox, I use that in a freezer bag and just wrap that up. That's sweet. What you can do is get a Vivid and write on big letters when its expiry is. So it's very easy for you to check when you do your kit checks. And with the little system, I've got one here, little boxes like this. You can get paracetamol, all your drugs. You can wrap your adrenaline vial in a bit of foam, and you have your needle and syringe and everything you need. All your meds that we've talked about here, you can store all that in there. This is now waterproof. And what you can do is, if you get either on the back or the clear lid, you get rid of the label, and if you put a bit of paper there with all your drugs and your expiry dates, then all you need to do is, if you haven't used any, when you're doing your gear checks every month or whatever, you literally pull this out and you can just read all the expiry dates on the front with even opening, and you know whether you're good or not. So that's my pro tip. Have a bit of paper on the top of it with what's in there and when it expires. And salbutamol, the inhaler goes inside the spacer. That's easy. And again, bit of paper on the inside of that, just with the expiry date written, or you can even write it on the inhaler, nice big Vivid. And then you know when it's going to expire. It makes your gear checks really quick and easy just to look at it. Oh yeah, we're all good. Obviously, don't try and keep it, cool, dry, and all that kind of stuff. Below 25 degrees, you should be sweet. Documentation standards. This is basically the minimum you need to extract from the patient before giving meds. And this basically means that your notes will be good enough, and it means I can audit you. And should the worst case scenario, I can contact the patient to make sure they're doing okay. Obviously, all this information will be kept confidential. I would say it goes without saying, but we're all used to confidential notes being vet providers and all that. But yeah, how you document it, I really don't care. As long as you document it, you can write it in a notepad. You can have your own PRFs. You can write it up later. However, I would advise writing notes when you're doing stuff is always better. Trying to remember times and exact things is much harder, particularly in an acute situation. So patient, we need to be able to identify the patient, name, date of birth, contact number, a brief kind of why you were there, what happened. And that can be, as I say, that patient fell over and hurt their leg, fell off mountain bike and hurt shoulder. Fell off a bank down 2 meters, sore right leg, past medical history. As it says, there you go. Specifically document nil if they have none. If you don't write it, you didn't ask it. If you write past medical history nil, it means you've asked and they said, I have none. That's how notes are interpreted. And I know that you guys will all be asking, but make sure you write nil if you're writing it, or tick the none if there's on your PRF. There are specific questions that I want you to ask about and document regarding both ondansetron and Penthrox, and that is, you want to specifically document that they have no malignant hyperpyrexia or no long QT. And that tells everyone who interprets these notes that you specifically asked that and the patient denied it. Some good tips about Penthrox: anesthetic family history and family history. Does anyone in your family have problems with anesthetic? Now, if Auntie Gladys has a hip replacement and was a bit nauseated afterwards, we don't really care about that. But a severe reaction, problems with anesthetics, those are the things that you need to be listening out for. Most of these guys do know it by name, as it's something that is potentially fatal for them. And we've talked about the long QT stuff as well. Unexpected death in the family, like if all their uncles have died at 25, then there's something going on there. So perhaps avoid that for ondansetron. Your exam, what you find, brief, focused. We don't need an essay here. It needs to be just bent right arm, fine, neurovascularly intact, sweet. When you're giving treatments, the drug, the dose, how you gave it, and the time. Recording other stuff like when you were called, when you got there, when you put a splint on, when you called for an ambulance, when the heli arrived. Those things are really handy if you need to do an after action debrief, because I can assure you that your recollection of when things will happen will be vastly different from what actually did happen.
Yep.
If you write it down as you go, then you know it's right. But man, time flies when you're having fun. And if shit's hitting the fan, you will find that an hour has gone by and you were like, well, when did this happen? I thought it was 5 minutes ago, but in reality it was actually 45. Obviously, if there's any adverse reactions and events, document those as well. And again, you don't have to write lengthy notes. So literally just a time and a brief note, and then you can, if you need to write a report later, you've got this to refer to. Some of you guys might have a dedicated patient reporting form, and it's got all the spaces for this on there. I know Lansar has got one now. It's not widely available, but there is one for Lansar. And basically, I would like to know about this within a week is probably fine. And how you get it to me, you can WhatsApp me, you can email me, however it works for you. And again, as I said at the beginning, if you do have any questions, comments, you want to ask about anything to do with this stuff, I am more than happy to talk about it.
Yeah, Paul, I've got a PRF I'm going to use up on the mountain. I can change the logo and send it around if you want.
Yeah, so the only other thing I will note that I don't kind of get stuck into too much in this lecture is the scope of the standing orders. The standing orders for Rescue 3 are while you are working for Rescue 3. They're not for when you're out with your mates, you're not for when doing other stuff, they are for while you are working for Rescue 3. And that's where I limit my exposure. If you do want standing orders for other things, to do other things, then sure, get in touch. We can talk about that separately. But these standing orders are specifically for when you're working for Rescue 3. Yeah, cool. Any questions?
No, straightforward.
Sure.
I do know, like we've gone through a whole lot of stuff in 45 minutes. So if you do have questions later, what I will do is I will file my contact details in the chat, and get in touch. Yeah, I mean, no questions at all? Stunned silence, too late at night, all want to go to bed?
No, it's all good.
Just one question, Paul.
Yep.
On when you were talking about adrenaline,
yep.
You mentioned having prednisone on hand.
That's if you are known to suffer from anaphylaxis and allergy stuff.
Okay.
So, like, if you're known to have it, anaphylaxis to stuff, there are two schools of thought. That some people think that you take prednisone after doing adrenaline because you might get this kind of rebound effect, and that's meant to damp that down. The other school of thought says, no, anaphylaxis is a separate cascade to your normal allergy stuff, and prednisone doesn't make a difference. adrenaline, and nothing else.
Okay.
Again, that's if you or your team members are known to have an anaphylactic reaction. That's something you can carry personally and take there. If you're treating someone for anaphylaxis in the field, or because you've given them like one of the other meds and they're having a reaction to it, or they've eaten peanuts or whatever, just give them the adrenaline and get them out of there.
Yeah.
There you
Okay.
go. And then someone else down the road can decide whether they want to give prednisone or not. In order to kind of do another standing order of prednisone, there's a whole lot more teaching and a whole lot more admin involved in that. It's a cool drug, prednisone, but yeah.
Cool,
Not
thanks.
first aid type stuff. Alrighty. Dan, how you going? You good?
Yeah. I'm making a few notes here for us instructors to talk about later. How
Okay.
we're gonna keep everything in place.
Yeah.
Dedicating a notebook for the drags and everything in one place. And potentially also we might have 1 or 2 medical kits, because
Yeah.
we're having quite a few different courses happening at the same time.
And we'll talk another time about me getting some meds over to you.
Yeah.
Yeah. In fact, I might be able to do that sooner. I might be able to get you some stuff pretty soon. The only thing will be because I'm currently planning to head over to the Redwoods on Sunday, so I might be able to drop some stuff off.
Cool, awesome. Yeah.
From a kind of technical point of view, as soon as you guys have done the quiz, and Andrew, one of the questions you answered was, I think you see where the difference is now. And it's basically, all the questions are good questions. Once you've done the quiz and I've emailed you to say, yep, we're all good, then you can start doing the stuff on the rest of it. If you've got a rescue 3 job on Sunday and you've done the quiz and I've emailed you back, then you can start giving these meds. Like you can literally go to Countdown, get some ibuprofen, paracetamol, and start giving these meds.
Okay.
Cool. Thank you.
Alrighty. If you do have any questions, guys, you've got my contact details. You've got a copy of the YouTube link to review this should you want. I think you've got a copy of the standing orders drive, Dan?
Yes, I forward it to everyone.
Yeah, so you got the standing orders as well, so you can go have a read. I also threw the cold card there, hypothermia, big into teaching about hypothermia. If you do any kind of rescue stuff, everyone is cold. Even if it's not winter, everyone's still cold. So the cold card is a really cool little tool that I advocate people printing out onto a little bit of waterproof paper, about yay big, and you can keep it in your kit with your notepad, and it's a great little aid memoir to refer to if you think someone's getting a little bit off. Cool. Well, I will leave you guys there, and you guys have a wonderful evening. Any questions, sing out, and thanks for coming.
Thank
Thank you,
you.
Paul.